and participate in a number of quality improvement processes, utilizing lean methodology.
Okay, so we're going to talk today about lean and PDSA. So just to get started, I wanted to give you a definition of lean. So basically, it's a methodology that's customer-centric, and it's used to improve processes by eliminating waste. And so we talk a lot about continuous improvement in lean and Six Sigma and respect for people. And so at Erlanger, we have a process improvement department, and right now there are two of us that are senior process improvement consultants. So we go out into the hospital and we do a lot of projects, and we always want to focus on our respect for people because we're going into other people's workspaces and trying to help them improve their processes. So that respect for people is important. So the purpose of lean is to improve performance and results, and by eliminating waste or removing as much waste as you can. And Dr. Bennet will cover waste in a little while. And also standardizing the work between employees and within a process. So when we started the department a few years ago and we used to teach lean, we had a lot of examples from other hospitals. And through the years, we've implemented a lot of things at Erlanger. So I'm proud that today we can talk about a lot of Erlanger examples where we've implemented lean. But I have a few just lean tools that I wanted to go over. But the first one here is tiered huddles. And you all might be aware of these or attend these. But if you look at the graphic here on the right, there is a tier 1 huddle daily, and these are the unit huddles that are done at the unit level. And then the tier 2 huddle is campus-wide. So for children's, I believe this is at 9 o'clock, and then for Baroness, it's at 9:30 every day. And then all of that rolls up into a tier 3 huddle, and that is when all the CEOs from all the different campuses report up to the C-suite. So the middle picture there, this is the huddle board for children's, and it really shows you what they go over every day. So the tiered huddles, their focus is on quality, safety, performance, and service. So some of the things covered every day, we talk about significant safety events and unexpected deaths, great catches and celebrations within the departments. And then if you look at the red and green dots here in the middle, this is the MESS board. And so it talks about methods, equipment, supplies, staffing, and safety. And so if any department has issues or opportunities with any of these, they can put a dot there on the board to discuss it. So the goal really of these tiered huddles is to resolve issues quickly and kind of get everyone on the same page for the day. And it really creates a good feedback loop. I think especially with maintenance and construction and EBS, we get a lot of response from them during these tiered huddles as well. So another tool in lean is standard work. And we are, when we get requests for this in our department, we work on rolling out standard work. And so there are a couple of different kinds. There's leader standard work, which is basically your daily to-do list. And there's also process standard work, which are work instructions. So this is our standard work form here. And this is for, I think, the bariatric coordinator. But you can see on the left, all of the essential tasks for this job are listed. And then you can see if they're performed daily, weekly, bi-weekly, or whatever that frequency is. So to do the standard work, when we want to write this for individuals, we really go out and do a lot of observations. So we're not sitting in our offices writing up how other people do work. We're going to each shift, so we can do night shift and morning shift or weekends, whatever, so we can get a good coverage. And then we're also interviewing employees and asking them how they do their jobs, what have they found is the best way or the most efficient, error-proof way to do their jobs. And we write up the standard work. And so this really helps, again, to put everyone on the same page. It helps you to figure out the best way to do things with the least amount of waste. And it really helps also, I think, when you're having people leave the company that have been here for many years and you want to pass on that tribal knowledge that they have, or when you're onboarding people, it's very helpful to be able to hand them the standard work and say, these are your expectations and here are your essential tasks. And it really helps them coming in to have some good work instructions. Another lean tool that we use is 5S, and it's basically a cleaning and organizational project. And the pictures here, this is actually a project that we did in the NICU supply room about, I think it's been about 3 to 4 years ago. And so the red boxes, those are our before, and then the green is after. But 5S projects, they're very methodical, like most things are in lean. So we go through these 5 S's that are listed here on the left, and we work to clean and organize these rooms. So in the sort phase, this is when you move out any of the unnecessary things that you need in the room or that you have in the room. And then you set these in order. And this is where you line up your supplies or whatever else you're using in that room, getting feedback from nursing or the people that do the work and asking them the best, most efficient place to put the products. And then you move on to shine. And this is when you bring in EBS or construction to clean or paint whatever is needed in the room. And then standardize, this is when you want to lock everything into place to sustain it, but you may implement audits, standard work here, rounding, and then the 5th S is sustainment. And this is really the hardest thing to do, is to sustain. But we've done several of these projects in and around the hospital and get a lot of requests for these. There's one going on in the children's surgery now. We've gone to the health centers, done the lab, just several different areas. So these are always really good projects that people get excited about, cleaning and organizing their workspace. And it usually does take a project because it's hard to do this on a day-to-day basis. All right, I'm gonna turn it over to Dr. Bennett.
Thanks, Nicole. Hopefully everybody can hear me. So the 10,000 foot view of lean as it's applied in any organization it's intended to align with its purpose, the organization's purpose in our work. That means aligning with our healthcare mission. And that focus on patients helps define what our processes are supposed to accomplish. If you then look at our processes, we attempt to align them with that goal, and we try to eliminate any waste steps in the process so that, in effect, the patient can get what they need with the least wear and tear possible. And I think a big foundation of lean in any organization is how it influences people. So it's fundamental that all people are respected, and that one of the key aims of organizational leaders are to develop people so that they can perform the tasks that are necessary and understand the processes so that healthcare can be delivered in an efficient and effective way. Next slide. So as Nicole said, a big focus of lean practices is to find and eliminate waste in our processes. So if you want to look at waste as any task or any effort that does not add value to the product or service from a customer's point of view, it helps you to understand what waste is. We sometimes think of waste in other terms. We often look at money, or we look at other things that seem like good ways of thinking about waste, but waste is actually a fairly insidious thing within processes, and you really need to have clear definitions in order to find it. Next slide. So starting with how we define value, value is basically from the customer's perspective, or in our world, the patient's perspective. And we want to have our processes basically aligned with those needs. And in order to do that, we have to, first of all, know if the process delivers what the customer expects. If so, then we are in fact delivering value. Within the processes, there are inevitably steps or things that we are doing that don't necessarily add direct support for that value. So non-value added basically might include trying to find stuff or doing stuff over again. or looking at the work that's already been done and making sure it's right. From a customer point of view, the fact that things should be done correctly is expected. If it takes us extra work to get there, that might be considered waste. Now, healthcare is a business, and we have to do business with a lot of third parties. And so all of the effort that goes into being able to bill a service may be considered waste, but if we didn't do that work, we wouldn't necessarily get paid. So some of this stuff is non-value added or wasteful from a customer's perspective, but still necessary in terms of the process as it exists. Next slide. Looking for waste is easier if you have some definitions, and this mnemonic is helpful to me to remember what the different definitions of waste would be. So these have each been defined with some examples from healthcare. So starting with the mnemonic downtime, D, defects. Basically, if you have a process that requires inspection, in other words, let's just say that you have a process that tends to be glitchy, like maybe it's a medical supply issue or a medicine supply issue, and you have to cross-check it for being accurate, that time spent is in effect a waste. However, if the process is glitchy to where it might produce defects, then you pretty much have to inspect it. Now, misdiagnosis, wrong side surgery would certainly be very doctor-oriented versions of defect. Overproduction is very common in healthcare. Basically, it means that we are either doing work that doesn't add value at the end of the day. It could be a situation where we're doing unnecessary everyday labs. So if we have QAM lab tests kind of as a default, then that might produce a lot of tests that we're not actually using to make decisions, and that would be considered overproduction. Waiting is everywhere. In fact, we build entire rooms and gigantic spaces for waiting. So you can see where wait occurs all through the system. However, there are other times when you are waiting for things like results from a previous test or something along those lines, which does in fact delay the ability to move the process forward. Non-utilized talent, really not valuing people is what this is about. People who have expertise doing their jobs undoubtedly have ideas about how those jobs could be improved, but many times they may not be asked for their ideas, or no one may come to them asking how things might get better. So that's one area. Another area would be having people working well below their training level. So, for example, having nurses making appointments, or having allied health professionals searching for materials. Transportation, we have to move patients all over the hospital in order to get certain things done. For example, getting them to radiology or getting them to another procedural area would still be considered a waste if that thing could be done without moving the patient. Inventory is a constant issue in healthcare. We have massive inventory needs, and as Nicole showed in her pictures, sometimes our inventory areas can become overwhelming. So managing inventory is a key opportunity in terms of waste reduction. You essentially want the right stuff in the right place, and you don't want too much of it such that it might, say, go out of date or might become obsolete. Motion waste really is about how much moving about it takes for you to do your work. So if you think about your work areas and having to go to 3 or 4 different sites in order to get what you need to do the job, that moving all over the place would be considered a motion waste. Extra processing is something where we're basically creating, say, additional requirements for getting information that we may not actually need. An opportunity would be not having to do H&Ps multiple times as a patient's being admitted. So if they're coming in through the ER having an H&P, then a medical student's doing an H&P, and then a resident's doing an H&P, you get the drift. So it tends to be a lot of extra steps that may not be necessary. Next slide. So this is really an exercise. If you were going to find waste, this is just an exercise for you to test those muscles. Nicole, the story starts off with a mom who basically is checking in for an appointment for a well child check. Now the mom had an appointment before that was rescheduled because the original appointment was canceled due to a physician vacation. So what kind of waste might you point out in this particular step? For me, this is a major problem with basically overproduction. So wherein you already had done the work to create an appointment, now you're having to redo that work in order to actually secure an appointment. And so the opportunity would be to prevent having to do the same job twice. Next one. So on check-in, the registrar notes that the patient is an hour late. Mom thought the appointment was 9:30, but the computer says it was 8:30. So this might be considered a defect. Information that was transferred was not confirmed, and that might be an opportunity for an improvement in the process. Next one. The next ones I'll kind of let you guys puzzle over. 20 minutes pass. Mom's there for 20 minutes waiting, and then informed that the doc will choose to see them. Registration then finds that the insurance has changed and the new information has to be collected, and then they're asked to wait for the next step of the process. Next step. So 15 minutes later, the MA brings the patient back, does the vital signs in the vital signs room, then goes to a different space to check weight and height, then walks the child to a back hallway for other intake steps, and then goes back to the original hall that they started in to find their exam room. And along the way, the MA makes a kind of a snide comment about it's important not to be late to appointments. Next one. After 10 more minutes pass, the physician enters the room, does the necessary physical exam and history, provides the guidance, enters some orders in for vaccination, and asks mom to make an appointment for a year later for a 5-year assessment. There's 13 minutes spent with the child in the room. And by the way, that 13 minutes is what the mother came for. So that 13 minutes is basically where the majority of the value is added. However, because of all of the kerfuffle up to this point, mom did forget to ask a couple of questions, and in part because she was worried about being able to make it to pick up her other child, given all of the time she's already spent in the clinic. Next one. So after a bit more time, the LPN enters the room with the syringes for immunizations and apologizes for that wait because he really couldn't find the paperwork that he needed that was required to give to mom, and therefore had to print new copies, only to find that the printer was actually out of paper, and he had to go to a back supply area where a huge supply of paper is stored. He does note that he wonders why they haven't stocked the paper near the printer like he had previously suggested at a group meeting. He does give the injections, and then the family is released from the clinic. Next one. That night, the physician is doing her documentation and records that the documented vaccine was actually expired. So she immediately fires off an angry email to her practice manager asking why expired vaccines are stocked in the clinic, then calls the mother to apologize and asks her to return for yet another visit in order to repeat the vaccination so that it will count for school. In the process of all of this, she forgets to document an enlarged lymph node that she had noted on the exam earlier that day. So in the context of all of this, you can probably identify a number of opportunities for process improvement because of the number of different wastes that the current process seems to be producing. This is wherein healthcare teams have an opportunity to see their care through the sight line of the customer, the patient themselves, and ask, is this value from their point of view? Is there a way that we can eliminate some unnecessary steps or eliminate some unnecessary time in order to deliver the value that the customer desires? Those are the opportunities that you will see through an application of lean in healthcare. Next slide. So what do you do? if you don't really think that you can influence these things, then you may only despair. You may only find that, this is just another day in the job, and you're just doomed to come back and grind it out another day. Or one of the things that you can gain through understanding and applying lean is that the discovery of a waste is actually a starting point to making things better. And that's what I hope that you take away from this talk. Next slide. I'll turn it over to Nicole.
All right, thank you. We have one more tool that we want to talk about, and this is something that in your quality projects that you'll be using, but it's PDSA, and it's a way to just quickly test changes on a small scale, and then you observe and document what happened, and you tweak and make the changes you want to make to your hypothesis, and then you test again. So it's a iterative 4-step management method. And so this is based on the scientific method, but as you see in the arrows, again, this talks about continuous improvement and process improvement, which goes hand in hand with lean. But I want to go over each of these steps in PDSA and just talk about some deliverables or good things to have when you do your a quality project. So planning is the first thing. And I think that this is really the most important step. And if you set yourself up for success and really think this through and plan everything out correctly, you'll be more successful with your project. But the first thing you want to do is write your aim statement. And there are aim statement worksheets out on the internet, mainly from IHI, and they can help you to quickly write a smart aim statement. And then next you plan your metrics. And I think that this is overlooked a lot of times is just, sitting down and really thinking about what metric do you want to improve, what your key measure is going to be, if changing that measure or that metric will affect anything else, if we'll have that waterbed effect on something else. And then you think about how can I measure it or collect it? So, you want to think about, is this something easy, a report that I can pull from Epic? Or is it something where I have to have an actual person manually collect the data from me? Because sometimes it is hard to get data when you need it. And then what type of data do you have? Is it qualitative? So is it something where you have to send out a survey monkey and ask people for their feedback and what their opinion is? Or quantitative, which I think is better if we have it, just to have some hard numbers. And then you need to establish a baseline chart. And so before any changes are made, it's important to get that data and get it charted so we know what the current state is. And then at this point, you want to think about your hypothesis and your potential interventions. So what can you do to change your aim statement? So you may think you have a magic bullet or something that you think would really fix the situation. And so you need to really consider feasibility at this point. So I always tell people to think about, is it practical, is it quick, and is it affordable? So if it meets these three things, I think it's good to go forward and do that. You want to walk through the test. You want to think about, you're probably not the person that's actually going to perform whatever test you're doing. So you want to think about, can that person that's going to carry it out do it? So really think about that and plan out your test. And then in the do part, this is where you carry out your test. And then all this time you want to definitely be collecting that post-intervention data. You want to document your problems and your unexpected observations. So is there anything that really surprised you, or did it turn out the way you thought it would turn out? Anything like that. The documentation is so important when doing these projects. And then you can begin to analyze your results. And so this may be where a coach or a mentor can come in and help with graphs or control charts. And then a couple of analytical tools I just put up here is a Pareto diagram and a fishbone diagram. And these are easy to use and I think helpful when using PDSA. And then study, you can move on, and this is when you complete your analysis and you want to look and see, did you improve from your baseline? And so this is again where maybe the mentor or coach would step in and test for statistical significance, or just see if your results remain the same, because your test may be to add more steps into your process or to do something differently. And if it didn't statistically change the process for the better, you want to stop doing that or take that out of your process if it makes it longer or more cumbersome for people. And then you want to say, you know, did I meet my desired target? And that's when you summarize and you reflect on what you learned. And again, document anything that you would think would be relative here. And then you can move on to ACT. So at this point, you want to say, did I meet the target of my aim statement? And if you did, you want to think about, how do I sustain this, or how do I lock this in? So this may be at this point where you might want to put in some audits. You may have to write up a policy and put in some kind of control plan at this point. If you did not meet your aim statement, then you want to refine that change and think about other things. Go back to the drawing board, ask some other people involved, what do you think would be a good change? And then at that point, you can go ahead and conduct another PDSA cycle and just continue doing so. So that is all for PDSA, and that's really all of our tools. I did want to plug here Lean 101 training. And if you are interested in learning more about Lean, we do offer a Lean 101 class, and it's an all-day interactive class. And you can sign up on the Erlanger intranet. And so you go under EOLs to sign up. And if you have any questions about it, you can reach out to me at my email. And do you have anybody have any questions?
Nicole, this is Alan Court. Could you check with the residents and see how many of them have ever participated in a tiered huddle or a patient safety huddle? Is there a way we can do raise of hands, find out how many people have done that?
I can't see that on my screen. I don't know if Kim can, or.
I have so far 2 participants raised their hand. That's it.
Okay. And the other question I had is, for every time you go through all of PEDS, okay, that's good. The other question I have is, do you have to do a statistical analysis for every PDSA cycle?
I think it depends. Dr. Bennett can answer, of course, too, but I think it depends on your chart. So if you have a control chart and you don't see any movement in your control chart, then it's not necessary to test for statistical significance. But if your chart starts going in a positive way or in a negative way, you may want to check for statistical significance at that point. But usually it's easy to tell, I think, by looking at a control chart.
Yeah, and I mean, for practical purposes, you know, if you're doing even weekly counts of an event or something simple like that, you can often determine if a change in your process is having what you would consider a meaningful impact on the event's interest. But a control chart, by its design, will tell you if you've created a change because you'll be out of control in a sense. So one of the things you're actually trying to do with a process improvement is take your process out of control in the right direction. So a control chart's a really excellent tool to answer that question. And if you have, in fact, taken it out of control in the direction of interest, then in effect, you have had a statistically meaningful effect on the process.
So what if I'm doing putting a new process into place, but I want to find out how well that new process works with the nurses who have to implement part of it. And sometimes we say in quality improvement, you want to test that new process with the smallest number possible. So say 4 or 5 nurses, I want to test it with. I'm not going to do a statistical analysis on that, but they may give me a lot of feedback that, hey, this process doesn't work for X, Y, Z reasons. Let's go back and revisit it. Or I may be doing a survey and I send the survey out, but I don't use SurveyMonkey or an easy tool, and I get very few responses. So there are a lot of little steps where you don't have to do a statistical analysis, correct?
Well, I think that's probably the biggest difference between quality improvement, say, a scientific experiment, in that with quality improvement, you're usually involving the people who do the work to find the waste and change the process to eliminate the wastes in the direction of the goal. So like what you're speaking to is probably an attempt to reduce a defect. So if a reduction in defect is a goal and you can pinpoint where in the process the defect is arising, then the people doing that work would be your key teammates in identifying the countermeasure that you're going to try in your PDSA. So if that countermeasure works, in other words, the workers can do it and they can do it effectively, and you see that it reduces the defect of interest, then you have succeeded in terms of your aim of reducing that particular defect. So I think the statistical analysis piece of this is not necessarily as much of a factor in the model as it might be, say, for a scientific project where you have to have a certain p-value in order to demonstrate a difference between one thing and another.
Any other questions?
Do we have our presentation still from Dr. Pickering?
Yes. Can you hear me?
Yes, John, we can hear you.
Okay, I'm gonna try to share my.
Go ahead and bring it up, and while you're bringing it up, I just want to say, John Pickering, for those of you who don't know him, is a resident in general surgery, and John had an excellent presentation. Actually, he just presented it also to the Quality Oversight Council of the hospital. But he had an excellent resident project last year that received second place on our quality day. So we've asked John to go ahead and present his project. So all of you will have a good role model of an excellent project that's been done by one of the residents. And so with that, John, are you ready to share your screen?
Yes. Do you guys see my presentation right now?
I don't. Did you go to share screen?
Let's see here. Let's see if this works.
You should be able to go down to the
browser. Yeah, sorry, my browser apparently doesn't have access to do it. Can Kim, do you want to try to pull it up for me? You said you had it.
Kim, are you there? There you go.
I apologize. My browser wasn't giving me the ability to do it.
Great. Thank you, Kim.
Oh, very nice. Okay. Okay. Well, thank you, Kim. I appreciate it. I guess I'll just tell you when to advance the slides. But as Dr. Court mentioned, I'm John Pickering. I'm a third-year surgery resident. I'd like to thank Dr. Court for asking me to present here, as well as the other meeting that he mentioned. I'd also like to thank Dr. Giles and Dr. Bhattacharya for helping me with my project. We can go to the next slide. So the aim statement of the quality improvement project was for us to have a 15% improvement in the intraoperative parathyroid hormone lab efficiency at Erlanger by May of 2020. And we'll talk a little bit more about what exactly that is. So a little bit of background. The diagnosis of hyperparathyroidism is relatively simple. It's a common problem. Really, if you have elevated calcium and elevated parathyroid hormone levels on your laboratory workup, you have your diagnosis. The treatment is primarily surgical. We use preoperative studies to try to identify the hyperfunctioning parathyroid glands. It usually consists of an ultrasound and sometimes a system EB scan. It's very critical to confirm that you are resecting the hypersecreting gland in surgery. And the standard of care here is to visualize all 4 glands and to confirm that you resected the right gland by documenting a 50% decrease in the parathyroid hormone level after you excise it. So yeah, intraoperative testing first helps confirm that you've performed a successful operation. It's been shown to improve cure rates and also helps to prevent failure of the operation and subsequent reoperation. However, next slide. It can be a very time-consuming process. So in these patients, they're brought to the operating room, intubated, prepped, and draped, and we make a neck incision. We expose the 4 parathyroid glands, and we remove what we think is the hypersecreting gland based on our preoperative studies. And after we resect this gland, there's a 10-minute no-touch period where we do not, do any more dissection to prevent the other glands from secreting parathyroid hormone and distorting our lab test. And you can stay on the slide. While we do this, so after we resected the gland, we send it down to the lab, and while the sample is in the lab, the surgeon, you can see the surgeons are waiting there with their hands crossed, waiting on the lab result. So there's no surgery being done during this time, and because we have to wait for the lab result to confirm that we've done a successful operation. So this can take anywhere from 20 to 45 minutes throughout the nation. And the average at Erlanger, as we'll show, was almost 45 minutes. So you can go to the next slide. I'm in here. Intraoperative parathyroid hormone testing has a lot of logistical challenges. It takes, as I said, 25 to 60 minutes throughout the nation. And this leads to patients being under anesthesia for a longer period of time. So this can lead to increased complications. Research has shown that every extra 30 minutes in the operating room leads to a 14% increase in complications. There's increased cost. Every minute in the operating room is said to cost about $36. And it's also very inefficient for the surgeon, for the hospital, and most importantly for the patient. Next slide. So our hypothesis was that the intraoperative parathyroid hormone lab result is both inefficient and highly variable at our institution. Next slide. So our prevention analysis, we first tested our hypothesis. We retrospectively looked at 85 patients who underwent parathyroidectomy, and the average lab result came back in 45 minutes. And there was a very pretty significant standard deviation and variability of this process of 21 minutes. Next slide. So again, our aim statement was to have a 15% improvement in the efficiency of this lab result. Next slide. So for our first PDSA cycle, as y'all previously discussed, Plan, Do, Study, Act, we did that in November of 2019. We had a very, very helpful and collaborative staff meeting where we talked to the scrub techs, we talked to the lab manager, we talked to the nurse manager, and we talked to both attending and resident or attending surgeons and surgery residents. We observed the entire process of the lab result. We were able to come up with a total of 72 steps that it takes just to get this lab result back. And we also did 3 simulations to test the interventions that we discussed at our staff meeting. Next slide. So in our first cycle, we did, as I said, 3 simulations, and we were able to show a 31% decrease in lab report time. These were obviously not real patients. We were, focused on just seeing how, we could do different things to make this a more efficient process. And we were able to see that we obviously could make a pretty significant difference if we just made a few small changes. Next slide. So, as I said, we had a significant improvement in efficiency and variability in the lab result during these simulations. It provided a controlled environment for us to test a lot of different ways that we could improve the process. This isn't a case that we do every day, so this kind of allowed us to make a lot of changes in a short period of time. It also established an attainable goal for us to shoot for in real cases. And probably most importantly, it identified 4 critical steps in the process that you can see on the right side of the screen. So from when the lab is initially drawn in the operating room to when it actually gets to the lab, from when the lab receives it to when the sample is put on the centrifuge, and then from the time from when it goes from the centrifuge to the actual machine that gets the parathyroid hormone result, and then from when the parathyroid hormone machine results to when the result is actually reported to the operating room. Next slide. So for our second cycle, we established interventions in real cases. Next slide. So these are each of our 4 critical steps, and these are the interventions that we made for each step. So for the OR to lab, so the lab had previously been transported on a dumbwaiter, which was thought to increase the efficiency of it, but it actually, once we dug into it, required the lab techs to walk all the way across the lab and kind of go out of their way from the busy work that they're otherwise doing, and led to delays. We also put a bright sticker insert on the lab that gave specific instructions to the OR nurses and the lab techs and everyone involved, so that the process was the same every single time, and because it was often different lab techs, different OR nurses doing it. So this kind of made the process the same every time, which improves the efficiency. From the lab, receiving it to putting on the centrifuge, we called the lab every morning. We had one of these cases to reserve the centrifuge machine. We also provided on bright sticker insert a direct phone number for the OR nurse and lab tech to call. The centrifuge to the PTH machine, we put alarms on the lab machines to let the lab techs know when they had resulted. We also called preoperatively to make sure the lab had calibrated the parathyroid hormone machine. There were a couple cases before in a pre-intervention analysis where the machine had not been calibrated, and that led to almost an hour of a delay in the result. And then again, the PDH machine to the operating room, staff education about the fact that the patient was under anesthesia during this whole process was very good, and it was also very good for the surgeons and the OR nurses to see from the lab's perspective, different things that went on in the lab that we weren't aware of. Next slide. So in this cycle, our lab report time, if you scroll down a little bit, so the far left is before our intervention, and the middle graph is after our intervention. And you can see a 19% decrease in the lab report time after our intervention, was just statistically significant. And also a very significant improvement in the standard deviation. And lab report time is from the very moment that we actually draw the sample to when it is actually called back to the operating room with the result. Next slide. So the previous slide was every single case. This slide kind of divides it into the main operating room and the plaza. So we changed in both of them. So the main OR, we were able to have a 28% decrease after our intervention. In Plaza OR, we had a 13% decrease after our intervention, and they're both statistically significant. And we'll talk a little bit about why I think we may have not been affected in the Plaza OR in a second. So analysis of cycle 2, as I said, we had a 19% decrease in all cases, which met our goal of a 15% decrease. We had a even more improvement in the efficiency in the main OR, which 28%, and 13% decrease in the Plaza OR. Next slide. So our conclusion, we achieved our goal in the main OR, but not the Plaza OR. We did achieve our goal overall. So what we found was that the nurse managers that we had our initial meeting with were not involved in the Plaza OR. So the main OR nurses received education and instituted all the interventions that we made, but the Plaza OR nurses did not. So that was a good learning point for us, and we actually have another resident who's currently working on getting the Plaza OR nurses involved, so that'll be our third PDSA cycle. And we're also establishing an email thread for continued monitoring and communication to try to ensure that we're able to sustain what we've been able to do. So I think one of the main conclusions I have for the study was how effective the collaboration with the lab techs, the OR managers, the surgeons, the residents, the nurses, how, early on in the study, we were able to involve everybody. And I think that really helped everyone buy in and really be involved, take ownership of the process. And I think that really helped us be effective. So I'd be glad to take any questions. And thank you again.
This is Alan Court. I don't have a question, John. I think it's more of a comment, and you've heard me say this before, but I think there are a lot of learning points on this, but I think one of the biggest ones is just the fact that you actually made a difference. You actually increased the safety because you had the patient out of anesthesia faster than you were doing before. And also you showed how you could work with another department within the hospital and actually help make a difference. That many times the project has to reach outside of your particular sphere of influence, and how well you can work with other components of the hospital and actually make a difference. This is just a great project, and one which really demonstrates so many different components of a good quality improvement project. So thanks again for doing that. And thanks to Jeff and Nicole for walking through PDSA cycles and the importance of lean. As we all know, you really don't learn about it until you actually have a project of your own where you walk through those and get a much better idea of the steps, whether it's a lean process or a model for improvement and PDSA process. Any other questions?
Thank you, everybody.
Thank you to everybody. Have a great day and stay safe.